Hi everyone, my name is S.H. Kim, and this time I would like to talk on the prevalence and practical imaging diagnosis of Nutcracker phenomenon and Nutcracker syndrome. This is a nut and a nutcracker simulating the mechanism of Nutcracker phenomenon, with the nut representing left renal vein and two arms of the nutcracker representing abdominal aorta and superior mesenteric artery. We need to be clear in the difference between the two terms, Nutcracker phenomenon and Nutcracker syndrome. Nutcracker phenomenon is just a phenomenon of compression of the left renal vein between the abdominal aorta and superior mesenteric artery, and it is called Nutcracker syndrome when Nutcracker phenomenon is accompanied by symptoms or signs such as hematuria, proteinuria, left flank pain, or other related symptoms. This is a photograph of Dr. De Schepper, a Belgian radiologist who first used the term Nutcracker syndrome in his historical article in 1972. Traditionally, the diagnosis of the Nutcracker phenomenon and Nutcracker syndrome depends on the pressure gradient more than 3 mm mercury across the aorta mesenteric left renal vein, but it needs an invasive catheterization. I had a special interest in the Doppler ultrasound diagnosis of the Nutcracker syndrome, and this is an article I published in 1996 in Radiology. Normally, there is a subtle compression and narrowing of the left renal vein between the abdominal aorta and superior mesenteric artery. And the normal peak flow velocity of the aorta mesenteric left renal vein is 40 to 50 centimeters per second, which is slightly higher than that of the hilar left renal vein, which is 10 to 20 centimeters per second. If the peak flow velocity at the aorta mesenteric left renal vein is higher than 80 to 100 centimeters per second, which is the twice of the normal velocity, 40 to 50 centimeters per second, we may make a diagnosis of Nutcracker phenomenon. If we calculate the theoretical pressure gradient from flow velocity 80 to 100 centimeters per second using this Bernoulli principle, the estimated gradient is between 2.39 and 3.81 millimeter mercury, which is quite equivalent to the 3 millimeter mercury pressure gradient criterion measured by catheterization. A 66-year-old man with microscopic hematuria without other cause for this hematuria. Color Doppler ultrasound well shows bright colored jetting flow from the compressed aorta mesenteric left renal vein, and the peak flow velocity was 143 centimeters per second, which is much higher than the normal velocity of 40 to 50 centimeters per second. And then we can make a diagnosis of Nutcracker syndrome without an invasive catheterization. A 36-year-old man with proteinuria and fluctuating glomerular filtration rate due to severe Nutcracker syndrome. Aorta mesenteric left renal vein is tightly compressed and absent flow signals in the dilated hilar left renal vein, indicating stagnant flow with peak flow velocity of 182 centimeters per second. In the severe Nutcracker syndrome like this patient, glomerular filtration rate of the morning and evening can be very different. As you see in those cases I showed you, Doppler ultrasound is a practical imaging modality to detect Nutcracker phenomenon non-invasively. Nowadays, CT became more and more popular as the primary imaging modality of the patients with hematuria. This is a 17-year-old man with gross hematuria due to Nutcracker syndrome. Early phase contrast-enhanced CT, while shows jetting of contrast-opacified flow across the narrow aortomesenteric left renal vein, and Doppler ultrasound confirmed the very high flow velocity, 226 centimeters per second. In 2011, my colleagues published this article in European Journal of Radiology reporting the findings of Nutcracker phenomenon and Nutcracker syndrome in CT. This is a big sign, and this is a narrow aortomesenteric angle described in this article. This is another article we published recently in Clinical Radiology, and we found that there are four patterns of contrast-opacified left renal vein flow. First, plug flow that is definitely normal, and the last is a jetting pattern that is definitely abnormal, indicating Nutcracker phenomenon. Two more patterns are flow of heavier contrast-opacified flow. One is along the dependent posterior margin of the left renal vein and inferior vena cava, indicating slow flow, and the other is along the non-dependent anterior margin, indicating faster flow. These pattern 1 and 2 indicate slow flow and absent Nutcracker phenomenon, while pattern 3 and 4 indicate faster flow and suggest Nutcracker phenomenon. This is a 40-year-old man with microscopic hematuria, and the flow pattern in this patient is type 3 along the non-dependent anterior margin, indicating fast flow, so positive Nutcracker phenomenon. A 53-year-old man, asymptomatic man with non-compressed left renal vein and normal plug flow pattern. Another asymptomatic man, slightly narrow aortomesenteric space, but contrast opacified flow along the dependent posterior margin, suggesting slow flow, so negative Nutcracker phenomenon. A 23-year-old man with gross hematuria due to Nutcracker syndrome, and cystoscopy showed gross hematuria from the left urethral orifice. Contrast-enhanced CT in early arterial phase showed flow of contrast-opacified blood along the anterior non-dependent margin, indicating fast flow, so positive Nutcracker phenomenon. A 17-year-old woman with proteinuria due to Nutcracker syndrome. Contrast-enhanced CT imaging in the early arterial phase showed the findings of subtle jetting flow and contrast-opacified blood along the non-dependent anterior margin after it passed a narrow space between the aorta and superior meningeal artery. The color Doppler ultrasound also shows bright colored fast flow along the non-dependent anterior margin, and peak flow velocity was 150 centimeters per second. There are variations of Nutcracker phenomenon, and at least 3 types exist. Type 1 is the classical type, compression of the left renal vein between the aorta and superior meningeal artery. Another type, type 2, is like this schema, compression of the left renal vein, not between the aorta and the superior meningeal artery, but left renal vein is compressed posteriorly by the origin of the right renal artery. And the third type is like this schema, left renal vein stretched over the abdominal aorta. And this is an example of type 2 Nutcracker phenomenon in an asymptomatic woman. If you look at the the left renal vein area carefully, you may notice that the left renal vein is not compressed between the aorta and supraventricular artery, but is compressed by the origin of the right renal artery, and the peak flow velocity was 114 centimeters per second. This is an example of type 3 Nutcracker phenomenon in an asymptomatic man. And in this patient, the space between the aorta and supraventricular artery is wide. There's no compression by the right renal artery, but left renal vein is stretched over the aorta like the schema, and peak flow velocity was 168 centimeters per second. Another patient with type 3 Nutcracker. This is a young woman with hematuria, proteinuria, and hypertension. CT shows this pattern of left renal vein stretched over the abdominal aorta and jetting of contrast opacified flow along the anterior margin of the left renal vein and inferior venous cava. A 62-year-old woman with left flank pain and bladder symptoms. CT images show compression of the left renal vein between the aorta and supraventricular artery, and also left renal vein is compressed posteriorly by the right renal artery, so combined type 1 and type 2 Nutcracker phenomenon. These findings are same as we see in ultrasound findings, but flow velocity information at Doppler ultrasound is a unique advantage of ultrasound over CT. Now I would like to talk about the postural variations of the Nutcracker phenomenon. A 25-year-old woman with microscopic hematuria, proteinuria, and a left flank pain due to Nutcracker syndrome. In supine position, typical type 1 Nutcracker phenomenon with flow jetting from the narrow aortomesenteric left renal vein. When the patient takes left lateral decubitus posture, superior mesenteric artery moves to the left side, and left renal vein compression is much relieved, and peak flow velocity was 51.7 centimeters per second, a normal value. And when the patient takes right lateral decubitus posture, superior mesenteric artery came back to the pre-aortic location, and left renal vein is again tightly compressed between the aorta and superior ventricular artery with peak flow velocity 220 centimeters per second. She told me that her usual sleeping posture was right lateral decubitus, and I explained about the Nutcracker syndrome and about the changes, Doppler findings with different postures, and recommended her to change the sleeping posture from right lateral decubitus to left lateral decubitus. And she came back to my clinic 1 week later with a bright smiling face and told me that left flank pain disappeared. This case well illustrates the ability of well-performed Doppler ultrasound examinations in the diagnosis and the management of a patient with Nutcracker syndrome. Another patient with a similar Doppler findings, 60-year-old woman with microscopic hematuria and low abdominal pain due to Nutcracker syndrome. Doppler ultrasound findings show similar difference of the movement of superior mesenteric artery and similar difference of left renal vein compression according to the postural changes. And her best sleeping posture will be left lateral decubitus. But in this 32-year-old woman with proteinuria, The movement of the mesenteric root containing superior mesenteric artery is quite limited, and the degree of compression of the left renal vein also similar in supine left lateral decubitus and right lateral decubitus postures with a similar peak flow velocity 177, 132, and 178. On the basis of Doppler ultrasound findings, we may suspect there are adhesions or fixations of the mesenteric root area in this patient, and we may expect changing the sleeping posture only will not be effective for the management of this patient. Now I'd like to talk on prevalence of Nutcracker phenomenon and Nutcracker syndrome. Nutcracker syndrome is known as a rare disease and is regarded as a rare disease in the 다시 합니다. 26번부터 다시 합니다. Now I would like to talk 26번부터 다시 합니다. Now I would like to talk about the prevalence of Nutcracker phenomenon and Nutcracker syndrome. Nutcracker syndrome is known as a rare disease and is registered as a rare disease in NIH and orphanage sites of the United States, but there are several articles reported it is not as rare as it has been known, and my opinion is Nutcracker phenomenon is a very common phenomenon, and Nutcracker syndrome is also quite common on the basis of my experience. I have reported my experience regarding the prevalence of Nutcracker phenomenon and Nutcracker syndrome in 2020 Annual Congress of the Korean Society of Ultrasound and Medicine. Among 1,223 patients examined with Doppler ultrasound in my clinic for 1 year, 372 patients, which is approximately 30%, were found to have Nutcracker phenomenon. And 184 of these 372 patients with Nutcracker phenomenon, so approximately 50%, could be diagnosed as a Nutcracker syndrome. This is a 28-year-old woman who was found to have proteinuria for 20 years, so from the childhood without any explainable cause. And the grayscale ultrasound shows narrowing of the aortomesenteric left renal vein, and the color Doppler ultrasound well shows jetting of bright colored flow from the narrowed aortomesenteric left renal vein, and the peak flow velocity was 147 centimeter per second. This is a case of Nutcracker syndrome, and this case belongs to this area of the diagram, Nutcracker syndrome with proteinuria. Another Nutcracker syndrome patient with intermittent left flank pain, and the ultrasound images show similar findings of narrowing of aortomesenteric left renal vein and bright colored high velocity flow with peak flow velocity of 220 centimeters per second. So she belongs to this area of the diagram, Nutcracker syndrome with left flank pain. Recently, we have done a study in patients with bladder cancer who underwent radical cystectomy and ileal neobladder formation. After surgery, these patients are usually followed up with regular CT examinations. If those patients show persistent microscopic hematuria, patients and the physicians, both sides, worry about the possibility of tumor recurrence, and follow-up CT results are important for them. Usually, kidneys, pelvic calyces, and ureters are closely evaluated for tumor recurrence, but the prevalence of upper tract tumor recurrence is not very high, approximately 5% at maximum in 5 years, and tumor recurrence at neobladder is extremely rare. Because I have a belief that prevalence of Nutcracker phenomenon is very high, approximately 30% at Doppler ultrasound study. I thought many of those patients with persistent microscopic hematuria are probably due to Nutcracker phenomenon and decided to have a study. We performed the study in 135 patients after radical cystectomy and ileal neobladder formation. And CT findings were evaluated or correlated with the frequency of hematuria in urinalysis examination. There were negative Nutcracker phenomenon findings like plug flow pattern or flow of contrast-specified blood along the dependent posterior margin in 92 patients, while there were positive findings like contrast-specified flow along the anterior non-dependent margin or jetting in 43 patients. And there was significant correlation between the incidence of persistent hematuria and those CT findings. This prevalence of 32% of positive CT findings is quite equivalent to this 30% prevalence at Doppler ultrasound study. This is a summary. Nutcracker phenomenon and Nutcracker syndrome are not rare, but quite common. Doppler ultrasound is the most practical non-invasive imaging modality for diagnosis, and we may have useful information regarding left renal vein flow at early phase contrast-enhanced CT to detect Nutcracker phenomenon. Thank you for joining this talk, and if you have any questions or comments, please email me.